Good morning, everyone. Welcome to our lecture on health economics. Today, we're going to dive into two core, interconnected concepts: health production and the demand for healthcare. Building on our previous discussions, we will now examine the theoretical and empirical links between socioeconomic factors, specifically income inequality, and health outcomes. This is a topic that has generated extensive debate and research in public health and economics. Following that, we will shift our focus to the demand for healthcare services. We'll explore the various factors that influence an individual's decision to seek medical care, including price, income, and insurance. The goal is to provide a comprehensive, nuanced understanding of why people demand health services and how different economic structures and policies can influence that demand. I encourage you to think critically about how these concepts relate to the public policy debates we see in the media every day in Canada. This slide lays out the structure of our lecture today. We'll begin by continuing our discussion of health production by focusing on the complex and often controversial relationship between income inequality and health outcomes. We'll explore the theoretical mechanisms that have been proposed, from evolutionary psychology to relative deprivation and psychosocial stress. We will also critically evaluate the empirical evidence for these theories from cross-country, within-country, and individual-level studies. The second major part of the lecture will shift to the demand for healthcare. We'll start with a foundational understanding of the demand curve, and then discuss the factors that shift it, such as price elasticity, income, and different types of health insurance. This two-part approach will help us link the macro-level socioeconomic factors with the micro-level decisions that individuals make about their health. We continue our discussion on the determinants of health with a deep dive into the theoretical links between income inequality and health. This is one of the most debated topics in health economics. The central question is, does living in an unequal society, regardless of your personal income, make you sicker? The first theory, rooted in evolutionary psychology, suggests that humans are predisposed to seek fairness. We evolved in small, egalitarian hunter-gatherer societies where sharing was key to survival. The argument is that our brains are not well adapted to the vast social hierarchies of modern society, and the stress of living in an unequal environment can lead to chronic illness. Another powerful theory is relative deprivation, which posits that psychosocial stress is the main pathway. In more unequal societies, there's more social stress, competition, and a lack of trust. In more equal societies, social networks and friendships provide a buffer against this stress. This theory suggests that it's not just about a lack of material goods, but about the constant psychological burden of being at the bottom of a social hierarchy. Finally, the relative income hypothesis suggests that it's not the absolute amount of money you have that matters for health, but your rank and income relative to others in your community. For example, a person with a low income in a high-cost area might be considered relatively poor even if they have more money than someone in a less expensive area who lives in a better house. This relative disadvantage can lead to lower access to resources and a lack of control over one's life, which in turn negatively impacts health. Now, let's turn to the evidence for the income inequality theories. As you can see, researchers have approached this question using a variety of empirical methods. The first approach is cross-country analysis. The challenge here is data comparability, especially in how different countries measure income inequality. Another approach is to compare different provinces or regions within a single country. This can be a bit easier since the data are often more consistent, but there may be less variation in inequality to study. Canada is a good example, with significant income inequality differences across provinces and territories. The third, and perhaps most robust, approach is to use individual-level data. This allows us to track the health of specific people over time, but it requires long-term data sets that are not always available. Finally, researchers often use mortality as a key health outcome measure because it is a clear, long-term indicator and is less subject to reporting biases than self-reported health. However, it requires a large sample size because it is a relatively rare event. Each of these approaches has its strengths and weaknesses, which is why the overall evidence is mixed. Let's look at some of the key empirical findings. The work of Richard Wilkinson in the 1990s was seminal in this field. He argued that in developed, wealthier countries, absolute income is less important for health than income inequality. He showed that as countries like France and Greece reduced their income inequality, they saw increases in life expectancy. Conversely, as Ireland and England saw their income distributions widen, life expectancy decreased. Wilkinson's core argument is that in wealthy societies, chronic diseases are the primary cause of death, and these diseases are often stress-related. He theorizes that social disadvantage, a product of income inequality, creates chronic stress, which then leads to these illnesses. However, it is important to note that the overall evidence from cross-country studies is mixed, possibly due to the difficulty of comparing data across different nations. For example, one of the most convincing studies, by Judge et al., found a link between income inequality and infant mortality, but this relationship was mainly driven by data from the United States, where other factors like race and systemic racism may play a significant role. Moving to within-country analysis, we see some strong relationships. For example, a well-known paper by Angus Deaton, 2003, shows a strong correlation between income inequality at the state level and mortality rates in the United States. The data suggests that a more unequal state has higher death rates. In fact, some studies, such as the one by Kawachi et al. 1997, made a very powerful claim that the loss of life attributable to income inequality was comparable to the combined loss of life from several major diseases and causes of death. This is a dramatic claim that underscores the potential importance of income inequality as a determinant of health. However, as we will discuss on the next slide, the causal mechanism is difficult to disentangle from other factors. Here, we introduce a critical caveat to the within-country evidence. When researchers attempt to control for factors like socioeconomic status and access to resources, the relationship between income inequality and health often weakens or disappears entirely. Studies in Canada have found mixed results on the link between income inequality and health. However, there is a clear and well-documented link between socioeconomic status and health. For instance, studies have shown that men in the poorest neighborhoods in Ontario die, on average, 5 years earlier than men in the richest neighborhoods. More importantly, this highlights the profound impact of systemic factors and racism, particularly for Indigenous peoples in Canada. For example, the life expectancy for Indigenous peoples is, on average, 8 years lower than the Canadian average, and infant mortality rates are up to 3 times higher in some communities. This highlights the problem of omitted variable bias, where an unobserved factor, like race, socioeconomic status, or political inequality is the true driver of the effect, and not income inequality per se. This slide introduces a fascinating and influential body of research from the Whitehall study. This study, which followed British civil servants, found a clear social gradient in health. It showed that the lower a civil servant's administrative rank, the higher their rates of morbidity, sickness, and mortality, death. This was true even after controlling for traditional risk factors like smoking or obesity. The researchers argue that income itself is not the underlying cause of these health discrepancies, but rather a marker of a person's socioeconomic status or rank. The lack of control over one's work life and the chronic stress of being in a lower status position were identified as the key drivers of ill health. This suggests that the negative health effects of inequality may be less about absolute money and more about the psychological and social burdens of one's position in a hierarchical society. Another theoretical lens through which to view inequality is political inequality. This theory suggests that in societies with a wide range of preferences, or what the slide calls heterogeneous preferences, it is more difficult for people to agree on the provision of public goods, such as healthcare. For example, if a community is racially or socioeconomically divided, people may be less willing to fund public services that they perceive as primarily benefiting a different group. This can lead to a lower provision of essential public goods like clean water, good roads, and public health services. The theory posits that this lack of collective action, driven by political and social divisions, is the true root of health disparities, not just income inequality itself. This slide provides compelling empirical evidence for the political inequality theory in a Canadian context. A major determinant of indigenous health is a legacy of colonial policies, such as the residential school system and the Indian Act, which created deep-seated systemic disadvantages. These policies fractured communities, disrupted cultural practices, and led to a lack of self-determination, all of which have profound and intergenerational impacts on health. A study from Statistics Canada shows that Indigenous people who are under the legal responsibility of the government as children report lower levels of self-rated health and poorer mental health as adults, which is a powerful example of how historical political arrangements have a lasting negative impact. The Truth and Reconciliation Commission of Canada's calls to action highlight the urgent need to address these health disparities by reforming the healthcare system and upholding the right to self-determination in healthcare for Indigenous peoples. Now, let's pivot to the second major topic of our lecture, the demand for health services. As we've learned, health is a result of many factors. Demand for health services, on the other hand, is a function of a specific set of variables. This slide lists some of the key drivers. We have the standard economic factors, price and income, which we'll explore in more detail. But unlike a typical product, demand for healthcare is also driven by unique factors like the type of insurance, and personal characteristics like age, existing health status, and even lifestyle choices. For example, a smoker will likely have a higher demand for certain types of health services than a non-smoker. We also need to consider the quality of care and the non-monetary time costs of getting that care. This demonstrates that modeling the demand for healthcare is much more complex than modeling the demand for a normal consumer good. This slide introduces the fundamental economic concept of a demand curve in the context of healthcare. The demand for health services is a derived demand. We don't want a doctor's visit or a prescription drug for its own sake. We want it because we believe it will improve our health. So, the demand for healthcare is derived from our desire for good health. As with any good, the law of demand applies. There is an inverse relationship between price and quantity demanded. When the price of health services goes up, the quantity demanded goes down, and vice versa. This relationship is shown by a movement along the demand curve, as illustrated in a typical demand curve graph. This is our basic starting point for understanding how people react to changes in the cost of health services. The concept of a standard demand curve, while a useful starting point, is too simplistic for the healthcare market. That's why we use the idea of a fuzzy or thick demand curve. The relationship between a specific type of care and a health improvement is often not exact. There is significant uncertainty. As consumers, we lack the specialized medical knowledge to know exactly what care we need. We must rely on a physician to make those decisions for us. This creates a situation where the physician acts as an agent for the consumer, which is not a typical arrangement in a consumer market. It is the physician, not the patient, who effectively determines the quantity of care that is demanded. This is why for a given price, we might see a wide range of quantities demanded, creating a thick, rather than a thin, demand curve. This adds significant complexity to the standard economic model of supply and demand. This slide introduces a key concept for understanding the effect of price elasticity of demand. This is a measure of how responsive the quantity demanded of a good is to change in its price. We have two theoretical extremes. Perfectly inelastic demand, where E equals 0, means that a change in price has no effect on the quantity demanded. This would be the case for a life-saving drug with no substitutes. The other extreme is perfectly elastic demand, where E equals, where a small change in price leads to a massive change in quantity demanded. Healthcare services are generally considered inelastic, meaning that even if the price goes up, people will still demand a relatively similar amount of care, especially for necessary services. This is why some policymakers argue that increasing patient out-of-pocket costs will not significantly reduce the demand for care, but will reduce unnecessary visits. Let's explain the diagram on the right. Look at the left side of the diagram. This represents perfectly inelastic demand. You can see the demand curve as a perfectly straight, vertical line. What does this mean in practice? It means that no matter how high the price goes, the quantity demanded doesn't change at all. Why would this happen in healthcare? Think about a life-saving medication. If a patient needs insulin to survive, They will buy it regardless of the price. The demand is completely unresponsive to price changes. The elasticity calculation here is E equals 0 because the percentage change in quantity is 0. The slope of the curve is infinite now. Let's shift our focus to the right side of the slide. This shows perfectly elastic demand. The demand curve here is a perfectly horizontal line. This is the opposite extreme. A perfectly elastic good is one where even the slightest change in price leads to a massive, or even infinite, change in the quantity demanded. In healthcare, this scenario is very rare, but we can think of it in terms of highly competitive, non-essential services, like a cosmetic procedure. If a clinic suddenly raises the price of a cosmetic treatment, patients might instantly switch to a different provider offering the same service. The demand is incredibly sensitive. The calculation for this is E equals, because a tiny price change, approaching 0, causes a huge change in quantity. Finally, in the center, we have the general condition for an elastic good, E minus 1. This is the most common scenario for many goods and services, including some in healthcare. It means that the quantity demanded is highly responsive to price changes. A 10% price increase, for example, would lead to a greater than 10% drop in quantity demanded. To summarize, in healthcare, we see the full spectrum of elasticity, from perfectly inelastic, life-saving drugs to more elastic services. Understanding this is crucial for policymakers and providers when setting prices and understanding market behavior. Now, let's look at some real-world data. The empirical estimates for the price elasticity of demand for healthcare are generally low, typically ranging between -0.1 and -0.7. What this means in practice is that a 10% increase in the price of primary care, for example, would only lead to a 1% to 7% decrease in the quantity of care demanded. This confirms that the demand for these services is inelastic. This finding has significant policy implications. For example, some argue that increasing co-payments or deductibles for patients can help control costs without significantly impacting access to necessary care. The thinking is that people will be more mindful of unnecessary visits, while still seeking care for serious conditions. I hope the explanations for price elasticity were complete. If you are more interested in learning more in details, please consider looking into more information by searching online. Thank you for your attention.